Robert was 72 when the pain started, not in his prostate, not when urinating, in his lower back, deep, constant, worse at night. He thought it was from gardening, took ibuprofen, the pain didn't stop. 3 weeks later, he lifted a box in the basement and felt something break, not the box, his vertebra. In the emergency room, the X-ray showed bones that were too white, too dense, chaotic. The doctor ordered a CT scan, then a PSA, then a biopsy, prostate cancer, Gleason score 9, bone metastasis in spine, ribs, pelvis. Robert looked at the doctor and asked, "But I had a PSA 3 years ago. It was normal. How did this get to my bones without me knowing?" The answer he received was vague: genetics, bad luck, aggressiveness. But the real truth, the truth nobody explained to Robert, is that his cancer didn't simply spread to his bones. It built roads there. It prepared the ground. It sent chemical signals months before the cancer cells arrived. And it did all of this without any test detecting it, because there's a hidden system operating inside prostate cancer, a system most men never hear about until it's too late. That system is angiogenesis, the creation of new blood vessels, and it's why some prostate cancers stay silent for decades, while others become lethal in months. My name is Dr. Jane. I'm a physician specializing in male urological health with 18 years of clinical experience. And what I'm going to show you over the next 20 minutes will completely change how you understand prostate cancer. Because it's not just about PSA, it's not just about hormones, it's about how a microscopic tumor learns to feed itself, how it hijacks your body's blood vessel system, and how it prepares your bones for invasion before you feel a single symptom. Before we dive into the mechanism, let me give you the numbers. Prostate cancer is the most common non-skin cancer in men in the United States. In 2024, nearly 300,000 new cases are expected, more than 35,000 deaths. Globally, it's the second most common cancer in men. 1.5 million new cases, nearly 400,000 deaths. The average age at diagnosis is 67. But here's what surprises most people. Autopsy studies show that more than half of men over 79 have histologic evidence of prostate cancer. In other words, the cancer is there, even though it never caused symptoms, even though it was never diagnosed. This tells us something critical. Most prostate cancers are slow growing. Most will never become fatal. The lifetime risk of being diagnosed is about 11%, but the lifetime risk of dying from it is much lower, about 2.5%. So the real problem isn't prostate cancer itself. The real problem is aggressive prostate cancer, the kind that escapes the prostate, the kind that spreads. And there are important disparities here. Black men have significantly higher prostate cancer incidence and more than double the mortality rate compared to white men. These differences reflect biology, access to care, quality of care, and social determinants of health. Genetics also matter a lot. More than half of prostate cancer risk is attributable to inherited factors. Men with mutations in DNA repair genes like BRCA2 carry significantly higher risk, including risk for earlier and more aggressive disease. Once diagnosed, one of the most important predictors of outcome is the Gleason score, now often grouped into grade groups 1 through 5. Lower grade tumors tend to behave much better. Higher grade tumors are much more likely to recur, spread, and become lethal. And this is where the story becomes urgent. About 75% of men are diagnosed when the disease is still localized to the prostate. At that stage, 5-year survival is nearly 100%, but about 10% already have distant metastasis at diagnosis, and 5-year survival drops dramatically. So the real question is, how does a localized prostate cancer become metastatic? And why does it so often go to bone? Because more than 90% of men with metastatic castration-resistant prostate cancer develop bone metastasis. That's not random. That's not chance. That's biology. Prostate cancer has what we call bone tropism. It's drawn to bone, but it doesn't just arrive there passively. It actively prepares the bone environment before it gets there. And once it arrives, it changes the entire bone remodeling system. Most cancers that spread to bone cause bone destruction. Prostate cancer is different. It tends to create osteoblastic metastases, meaning it stimulates abnormal bone formation. That sounds good at first, but it isn't. This new bone is chaotic, dense, poorly organized, and structurally weak. It sets the stage for fractures, spinal cord compression, severe pain, and major skeletal complications. So what drives all of this? One answer lies in a process you can't see on a scan: the angiogenic switch. A tiny cluster of prostate cancer cells can only grow to about 2 to 3 millimeters before it runs out of oxygen and nutrients. Without its own blood supply, it hits a wall. It can remain dormant for years, invisible and clinically silent. But if angiogenesis gets switched on, everything changes. The tumor learns to feed itself. And in prostate cancer, one of the major drivers of that switch is the very same hormone system that normally keeps the prostate healthy. This is the paradox. Prostate cancer is a hormone-driven disease. Androgens like testosterone and DHT are necessary for normal prostate function. But in cancer, those same hormones become fuel. And one of the most important ways they do this is by increasing VEGF, vascular endothelial growth factor. VEGF is the master driver of blood vessel growth, and androgens directly increase its expression. When prostate cells are exposed to androgens, VEGF levels rise. When androgens are removed, VEGF levels drop. This isn't just a side effect, it's a central mechanism, but it gets more interesting. Androgens don't just stimulate VEGF directly, they also stabilize a protein called HIF-1 alpha. Normally, HIF-1 alpha is degraded when oxygen is present, but androgens can keep it active even when oxygen is normal. This creates what researchers call pseudohypoxia. The cell behaves as if it's oxygen-starved even when it's not. And once HIF-1 alpha is active, it strongly drives VEGF production. So now the tumor has a powerful growth system. Hormones activate HIF-1 alpha. HIF-1 alpha activates VEGF. VEGF activates angiogenesis, and the tumor gains blood supply. There's also an autocrine loop involved. In simple terms, prostate cancer cells don't just receive growth signals from outside, they start producing signals that stimulate themselves. They secrete growth factors, activate internal pathways like PI3K and AKT, and amplify their own ability to grow and survive. This is one reason androgen deprivation therapy works so well at first. You remove the hormones, VEGF levels fall, blood vessels regress, tumors shrink. But then resistance develops. Because tumors adapt, they find other ways to activate the same pathways. And once they do, the disease becomes much harder to control. Now, VEGF isn't the only player. Prostate cancer also produces fibroblast growth factor 2, FGF2. This molecule can help sustain angiogenesis even when VEGF is blocked. That means if you target one pathway, the tumor may simply switch to another. And prostate cancer cells don't just secrete VEGF and FGF2. They also express the receptors for those signals, so they create a self-feeding loop. VEGF binds to receptors on the tumor cell. That activates internal signaling like mTOR. That leads to even more VEGF production. The signal gets louder and louder. This helps explain why angiogenesis becomes so powerful in aggressive prostate cancer. But the blood supply in the primary tumor is only part of the story, because metastasis to bone begins even before cancer cells arrive there. This is where the concept of the pre-metastatic niche comes in. Before tumor cells reach bone, The primary tumor sends out tiny vesicles called exosomes into the bloodstream. These exosomes carry proteins and signals that travel to distant sites. In prostate cancer, exosomes carrying an enzyme called PKM2 can be taken up by bone marrow stromal cells. Once that happens, those stromal cells begin activating HIF-1 alpha and producing CXCL12, a chemical signal that acts almost like a homing beacon for incoming tumor cells. So the bone is being prepared in advance. The cancer isn't just spreading, it's landscaping the destination before it arrives. And once prostate cancer cells reach bone, the environment itself amplifies the disease. Bone contains growth signals like bone morphogenetic proteins, BMPs. These can stimulate prostate cancer cells to produce even more VEGF. So now the bone microenvironment is helping drive angiogenesis, and angiogenesis is helping the metastatic tumor establish itself. VEGF also directly stimulates osteoblast activity, contributing to the abnormal bone formation that defines these metastases. At this point, you might think, well, then why not just block VEGF? That seems logical. If angiogenesis is so important, anti-angiogenic drugs should work really well. But this is where things get frustrating. They haven't worked nearly as well as expected. Clinical trials using VEGF inhibitors like bevacizumab and other anti-angiogenic drugs in prostate cancer have generally failed to improve overall survival. Why? Because the tumor is redundant. Block VEGF, and it may increase FGF signaling, or interleukin-8, or angiopoietin-2, or shift to a different vascular strategy entirely. There's also the issue of hypoxia-induced resistance. If you block blood vessel growth, the tumor becomes more hypoxic. That activates HIF-1 alpha even more, and HIF-1 alpha doesn't just drive angiogenesis. It can also drive invasion, metastasis, and treatment resistance. So sometimes by trying to starve the tumor, you can inadvertently push it into a more aggressive state. There's also vascular heterogeneity. Not every tumor vessel depends on VEGF. Some tumors grow along pre-existing blood vessels. Others develop vessel-like channels from the cancer cells themselves. These pathways are less sensitive to anti-VEGF therapy. This is why researchers increasingly believe that single-pathway angiogenesis blockade isn't enough. The future probably lies in combinations. Multiple angiogenic targets, plus hormone therapy, plus chemotherapy, maybe even plus immunotherapy. And that brings us to another important layer, the immune system. VEGF doesn't just help build blood vessels, it also suppresses immune function. High VEGF levels interfere with dendritic cell maturation. And dendritic cells are critical because they're the scouts of the immune system. They sample the environment, collect abnormal antigens from cancer cells, and present those antigens to T cells. Without functional dendritic cells, your T cells never get properly activated, and that means the tumor remains hidden. VEGF also suppresses T cell activity directly and recruits immunosuppressive cells like regulatory T cells and myeloid-derived suppressor cells into the tumor microenvironment. So now you have a double problem. The tumor has blood supply and it has immune protection. That makes it harder to attack from either angle, but it also creates an opportunity. If you can target angiogenesis and immune suppression together, maybe you can weaken both systems at once. That's one reason researchers are so interested in combining angiogenesis inhibitors with immune-based therapies. Before we get to what you can do one thing for me. If you recognize at least one risk factor in your own life, age over 60, family history, black race, elevated PSA, leave a like right now. And in the comments, tell me, what's your current PSA? When was the last time you got tested? This will help me understand who's watching and what to cover in upcoming videos. Now let's bring this back to the patient. What can men actually do? First, understand that screening matters. PSA testing remains controversial because it can lead to overdiagnosis, but randomized trials show that screening in the right age groups reduces prostate cancer mortality. For many men, screening every few years between ages 50 and 69 is reasonable. For Black men and for men with strong family history or inherited risk, earlier screening may make sense. This is something to discuss with a doctor. What has improved the situation dramatically is MRI. Multiparametric MRI can identify suspicious lesions and guide targeted biopsies. That helps find significant cancers while reducing detection of low-risk disease that may never need treatment. And this matters because not all prostate cancers need to be treated immediately. For low-risk disease, active surveillance is now often preferred. That means following PSA, imaging, and biopsy over time rather than rushing into treatment. This avoids unnecessary side effects while still allowing intervention if the cancer changes. For advanced disease, treatment has expanded significantly. There are androgen receptor inhibitors, chemotherapy options, immunotherapy approaches, and bone-targeted agents. The key is understanding that each therapy attacks a different part of the biology, and that the disease often evolves over time. Now, let me be honest with you, the same way I am with every patient. Screening, MRI, active surveillance, all of this is fundamental. But there's something else men over 60 ask me every week. Doctor, is there anything I can do right now to reduce my risk? The answer is yes, but it needs to be based on science, not marketing. Regular exercise reduces risk of aggressive prostate cancer by up to 30%. A diet rich in cruciferous vegetables, cooked tomatoes, lycopene, and low in processed meats is associated with lower progression. But there are also specific nutritional compounds with preliminary anti-angiogenic evidence. EGCG, the active catechin in green tea extract, has been shown to inhibit VEGF and angiogenesis in vitro studies and animal models. Saw palmetto and pygeum reduce chronic inflammation, which is the initial trigger of the cascade leading to cancer. Zinc. The prostate needs more zinc than any other organ in the body. Zinc deficiency is associated with cancer progression. I've left a link in the description for a natural formula with over 20 clinically researched ingredients, including green tea extract rich in EGCG, saw palmetto, pygeum, and zinc. All of this working on the pathways we discussed: inflammation reduction, antioxidant support, preliminary VEGF inhibition. Let me be clear, this doesn't cure cancer, it doesn't replace PSA, it doesn't replace medical treatment, but it can be part of a science-based preventive strategy. No prescription needed, full 180-day money-back guarantee. If you're taking your prostate health seriously, doing screening, maintaining healthy weight, exercising, and want to add evidence-based nutritional support, that link is in the description. The bigger picture here is this: prostate cancer isn't just about one hormone or one mutation or one blood test. It's a complex disease that unfolds over years through inflammation, genetic vulnerability, hormonal signaling, angiogenesis, and microenvironmental change. The tumor grows by exploiting the body's own systems. Androgens drive VEGF. VEGF drives blood vessels. Blood vessels support growth and metastasis. Bone becomes a prepared landing site, and the immune system gets pushed aside. That's the hidden story, and that's why understanding angiogenesis matters so much. Because if we can understand how tumors build their supply lines, maybe we can stop the disease before it spreads. Maybe we can intervene earlier. Maybe we can identify which cancers are truly dangerous and which aren't. And maybe the future of treatment will depend less on reacting once metastasis occurs and more on identifying the switch before it turns on. You just received knowledge that most men never hear until it's too late. Robert, the 72-year-old man who opened this story, told me 6 months after his diagnosis, "Doctor, I wish I had known this 5 years ago. I would have done the PSA. I would have done the MRI. Maybe we would have caught it before it got to my bones." Don't be Robert. Don't wait for the pain. Don't wait for the fracture. Share this video with another man over 60 who needs it. Subscribe to the channel and leave in the comments, what's your current PSA? Take care of yourself out there.